Hi, everyone, again. Now we're lucky enough to have two major types of treatment options within our reach. Dr. Alex Menter, the KP Colorado subspecialty director, and I will discuss and have a conversation about immunotherapy and target therapy with a focus on their potential side effects. Okay, so focus on their potential side effects, some of their strategy to guide patients in dealing with their treatment and their symptoms. Okay, so first we will focus on the immunotherapy, then subsequently target therapy, which are tablets, pills. So what will patients feel in the infusion chair? What are the symptoms they should watch out for? Well, you can experience any of these symptoms. You would need to report to the infusion center nurse, especially with chills, flushing, difficulty breathing, and dizziness. Keep in mind that only very small percentage of patients experience these symptoms. So most of the patients leave our infusion center feeling well, and they were sent home after infusion. Then what should we watch out and monitor for? So these are some examples of immunotherapy. Dr. Menter, how do you counsel or introduce immunotherapy to your patients?
The way I tend to frame it is that a lot of patients will actually not have any side effects, particularly with the single agent drugs like nivolumab and pembrolizumab. But that a lot of people do have to watch for toxicities that can develop down the road, and that these are toxicities that are associated with an overactive immune system. So, some of the slightly more common ones are itching and rash. We certainly worry about diarrhea in some patients, which is similar in many ways to autoimmune conditions that attack the colon, like Crohn's disease. And then there's a whole bunch of crazy immune toxicities that can attack your endocrine glands, like thyroid dysfunction, and even ranging all the way in rare circumstances to people developing type 1 diabetes. So most people are going to do pretty well. Some people are going to get some mild toxicities. There are going to be some toxicities that are going to develop, and we're going to have to hold therapy or treat those side effects because they can be serious. I guess the other thing I say is that we really don't know in that first week usually if they're going to get side effects, because those side effects can develop in the first few weeks or in the first few months, and sometimes even later. So you really, unlike some chemotherapies that we give where you're going to kind of know in that first week what the side effects are like, I'd say here we're having to kind of wait and hold our breath a little bit to see what side effects will develop.
Yeah. Thank you. Yeah, I really emphasize with my patient as well, like Dr. Mentor, that symptoms may begin anytime, right? It could be within first few weeks, within first few months, and make sure that if you're getting to the point where you need to go to see other specialists, like endocrinologist, or you go to see your joint rheumatologist, you let them know you're on immunotherapy, and early detection equals early management, so that will help to mitigate some of the treatment side effects. Also, I would like to add, before the treatment start, I ask the patient to write down some of their baseline symptoms that will help us to assess which ones are new. For example, you have baseline irritable bowel disease, you have baseline sometimes diarrhea or arthritis. So you write them down. So when the nurse asks you in the infusion center, how many times a day do you have loose bowel movements, you will know that this is, even though yours it's 5 times for you, but that's abnormal for another patient. It might be a normal thing for you, Okay. So at home, you would like some of the common symptoms to monitor are diarrhea, fever, shortness of breath, feeling fatigued, some rash, headache, insomnia. You would like to monitor these symptoms at home. And we do have many websites, and this is one example of National Comprehensive Cancer Network provide a great deal of what side effect to monitor. They have patient education on what side effects patient may develop based on their symptoms. Okay. So Dr. Menter, when do you use steroids or immunosuppression, or maybe ask a patient to see a specialist?
So I think on our end, just so patients are aware, we're looking at something called the grade of a toxicity. So if someone has diarrhea, we're going to kind of look at their change in their bowels and say, is this grade 1, grade 2, grade 3, or grade 4? Those are things that help us sort of categorize these side effects and decide, is this something that we need to intervene on? I don't think people need to know the grades. I think as a general rule, what we're looking for is this something that's kind of mild and an annoyance, but something they can live with? Is it something that is, disruptive and it's not going to be a side effect that people can deal with over long periods of time? Or is this a real serious side effect that could put someone in the hospital or could be life-threatening if we don't manage it over time? Certainly when you tap into that third category where we're worried about serious organ dysfunction, hospitalization, or even in some cases death, we're going to hold treatment and we're going to usually give them some kind of immune suppression to try and suppress the immune inflammation that's causing that side effect.
Yeah, thank you very much. And we sometimes re-challenge if the side effects is well controlled, right? Okay, so again, this slide is to show that there are some special patient population that may not be excellent candidate for immunosuppression treatments, such as a patient receive organ transplant, patient with uncontrolled autoimmune diseases. And there's very rare side effects, all less than 2%, that may be severe, but should not deter a patient from immunotherapy, a potentially life-saving treatment. Okay. Dr. Menter, what are some potential long-term side effects, and how do you suggest patients deal with these potential long-term side effects once they occur?
I think to some degree, sometimes we're looking at which of these side effects are potentially organ damaging, like type 1 diabetes, which is very rare. But if you get type 1 diabetes, we kind of know how to manage it. And depending on, the situation with the melanoma, sometimes the melanoma is the greater risk. So we're just going to kind of manage the diabetes and kind of do our best and continue to manage the melanoma with immune therapy. On the other hand, there can be some real serious side effects like pneumonitis or liver inflammation. Pneumonitis is lung inflammation, where if those get real severe, and especially if they recur after we re-challenge, we may not be able to give additional immune therapy. What I tell people also is it's not 100% with any given patient, but some people who develop some of these severe toxicities, even after just a few months of treatment, can still have long-lasting benefit in terms of their melanoma. So we're still working out what the ideal length of treatment is, but for some people where we've had to stop treatment due to severe side effects or treat them with steroids, some of those people are still doing well with good melanoma control years later, even after just a few months of therapy. So it's not always disastrous to have to hold treatment for toxicities in regards to controlling the melanoma.
Yes, if your disease are improving quite a bit and your patient's appetite for potential side effect, long-term side effect tend to increase, right? If the treatment is working fabulously, right? As far as diabetes, sometimes we ask endocrinologists, especially with pituitary inflammation, just to replace the missing hormones so that patient can continue treatment. It's not the end of the world, right? So we move on now. Thank you. We can to target therapy. So some of the target therapy available agents are listed right here on the left side of the slide. And some of the common side effects, it's not all inclusive, potential side effects are listed on the right. Some of the more common ones are fever, rash, and could cause photosensitivity and joint discomfort. So Dr. Menter, how are these side effects different than the immunotherapy agents in terms of length and the types?
Yeah. In some ways, many of the same organs can be affected. You can get diarrhea, you can get inflammation in the lungs, you can get inflammation in the liver. To some degree, there are some differences in the percentages of patients that experience those. I will say one thing that is a big difference is that with targeted therapies, these toxicities tend to be dose related. And so someone who may be having a lot of fatigue or diarrhea or rash at one dose with the targeted therapy, they may do very well with a dose reduction in their treatment, and they may still have good disease control even at a lower dose. So that's something that we usually start out at the FDA approved dose, but we usually feel comfortable making adjustments to that to make sure that this is a treatment that you can tolerate over the longer term. With immune therapy, it's more of a lottery, and there's really not as much of an effect of the dose of the immune therapy. It's either there or it isn't. And we kind of have to manage it with either continued therapy or hold therapy, steroids, no steroids, et cetera. So it's a little bit different in terms of how we manage them over time.
Yeah, thank you. Dr. Menter, we live in a Southern California sunshine state. So skin toxicity is particularly difficult to deal with. For rash and skin toxicity related to target therapy, there's a variety of them that could happen, like a hive. Some of them look like acne. Some of them are hyperkeratotic, and small percentage of patients get squamous cell carcinoma, very small amount. It will be preferred that these patients are followed by dermatologists while on these treatments, and wear some protective clothing as well as sunscreen on daily basis, especially when they go out in the summer. And Dr. Menter, what can we do in helping patients to continue these treatments, particular target therapy?
As I mentioned before, sometimes if it's a side effect that it's just going to be difficult to maintain over indefinite length of time or over a year, then we may have to do some dose reductions. For people who are experiencing fevers as a result of treatment, sometimes staying well hydrated and taking Tylenol on a regular basis can help. And it really otherwise just depends on the side effect in terms of whether or not it's a dose reduction or whether or not it is something we just kind of live with for the potential benefit of the therapy. And then I'll also just say it depends a little bit on the setting of the disease. When we're treating someone who had surgery and we're treating in what we call the adjuvant setting, meaning that we might have gotten all the cancer, but we're not sure. Sometimes there's a sort of a different approach to these toxicities compared to someone where they have stage 4 cancer, and this is really our best chance to control their a life-threatening disease. So you have to look at the setting and sort of how the patient is tolerating it and what their quality of life looks like, and then make adjustments based on that.
Yeah, absolutely. Yeah, it's an adjuvant setting versus a stage 4 setting. You give you may even think about dose reduction adjuvant setting, even a treatment holiday, right? Mm-hmm. Certainly. So our last question on this session is, given all these side effect profile in these two major class of treatment, do these side effect profile affect your choice of treatment in the first line metastatic setting and also in the adjuvant setting? The long question.
I mean, I alluded to it to some degree. I will say that, and this is going to come up in some sessions later today, It used to be that we didn't know whether it was better to start with BRAF treatment or immune therapy for people who have stage 4 cancer where we need to initiate treatment. We now have some clinical trial evidence that was generated in part by Kaiser and the National Cancer Institute that says it's better to start with immune therapy and then move to the BRAF treatment for people who have metastatic disease. Despite that, there may be some people who have to be on real high doses of steroids or they have an immune condition already, where we're going to have to start with BRAF treatment because we just don't have another choice in that setting. The other thing that sometimes affects how we choose our agents early on is the presence of brain metastases, which is unfortunately something that is relatively more common with melanoma relative to some other cancers. And so sort of our approach to those sites of disease may sometimes affect whether or not we're going with a targeted therapy or an immune-related treatment. And then finally, what are the medical conditions of the patient? If it's someone who already has an immune colitis condition or maybe bad rheumatoid arthritis or they're on immune suppression, that may push us more towards the BRAF type treatments. So anyway, there's a bunch of factors that go into it in addition to patient preference.
Yeah, thank you. So Dr. Menter, you're initially referring to the DREAMseq trial that provide more and more data to support immunotherapy in the first line setting in the metastatic disease setting. Kaiser Permanente participated in the study. For patients, a follow-up question for patients who are very concerned about toxicity, such as kind of well-controlled ulcerative colitis, how do you decide between one PD-1 inhibitor versus double or two immunotherapy agents together?
So I think for me, I'm always looking at sort of how's a patient's overall health and strength and functional status. The combination therapy, especially with ipilimumab and nivolumab, which is one of the more common combinations that we've used, a lot of people get pretty significant toxicity from that compared to when you're using a single agent treatment like nivolumab or pembrolizumab. I have to kind of look at the patient and think that they can take some toxicity if we're going to do the combination therapy. And then, of course, there's the issue of again, how much disease do they have, and sort of how urgent is a response, because the response rates are higher with the combination treatment.
Yeah, thank you. We want to be very clear that you're saying that two drugs in terms of immunotherapy are definitely more toxic than one, single agent nivo or single agent pembro, but almost the opposite for BRAF MEK inhibitor, right? The two drugs used together the combination may have less toxicity for patients, right?
Yeah, so, less skin cancers for sure.
Right, less skin cancer. So for adjuvant, in the adjuvant setting, I tend to use immunotherapy because I think that you activate the immune system and keep the cancer in check even when you're finished and completed the immunotherapy adjuvant. However, I do have some patients, especially young patients, who I did use BRAF MEK as an adjuvant in the adjuvant setting. What are some patients that you would elect the target therapy as adjuvant setting?
There was, for instance, a patient who where we actually tried the immune therapy, but they had recurrent pneumonitis, and we just couldn't give them more. Where and then they had a subsequent in transit recurrence that we removed, and we decided to do the BRAF treatment after that. And then again, people with autoimmune toxicities. I agree with you. I tend to prefer immunotherapy in the adjuvant setting, but I also admit that there's a fair amount of uncertainty here, and that the BRAF drugs have been shown to improve survival. And although we're still sort of sorting some of these things out, it's possible that when you have a really good response in the adjuvant setting, that even with the BRAF drugs, that there may be some long-term cures as a result of that. So anyway, I think we're still kind of sorting out how to compare the long-term results of both of those.
Yeah, thank you. And here are some resources and very good education materials for our patients that's available in AIM and Melanoma Foundation, as well as American Cancer Society. And now let me unshare my screen and move on to the next session.